كارديوفاسكولار ما في بوينتر نمسك هاي لا انا بنقل بس من البوينتر. اوكي شكرا للجميع ومساء الخير واهلا وسهلا فيكم. هتحدث معكم اليوم عن type 2 diabetes as a cardiometabolic syndrome. Although the focus of the meeting is type 2 diabetes, but now we are in an exciting time where we are finding that type 2 diabetes is very closely related to cardiovascular disease. And about this subject, I'm going to tell you about that diabetes basically is a different shape or different manifestation of cardiovascular disease. And we long know that cardiovascular disease are very important in type 2 diabetes because over 80% of our patients who have type 2 diabetes ultimately are going to die from cardiovascular cause. And this study demonstrates the importance of diabetes and cardiovascular disease. And as you can see here, this is a study that was done in Scandinavia and Finland, and in which they divided people into either have diabetes at baseline or don't have diabetes. And then each subgroup were divided, either they have cardiovascular disease and they don't have cardiovascular disease. So if we look at people who don't have diabetes at baseline, we see that if they had cardiovascular disease, the risk of having a cardiovascular disease or death within 7 to 8 years is about 5-fold that of people who don't have cardiovascular disease. Meaning, if you have a cardiovascular disease, that increases your risk of having a second event. That's not surprising. But if you look at people who have diabetes, and then those who have diabetes without cardiovascular disease, you would see that the risk of having another cardiovascular event or death is exactly very similar to that of people who have existing cardiovascular disease but don't have diabetes. So in other words, the risk conferred by the presence of diabetes is very similar to that of cardiovascular disease. And since then, the presence of diabetes is considered as a risk equivalent to the presence of cardiovascular disease. Of course, if you have diabetes and cardiovascular disease, then your risk is doubled. And that shows you that the risk conferred by diabetes is somehow different than that caused by cardiovascular disease. Now, why people with diabetes have high risk of cardiovascular disease? Is it the glucose? Because diabetes is a syndrome of glucose metabolism. It has hyperglycemia as a central feature of type 2 diabetes, so must be glucose. And this is data from the UKPDS in which they looked at lowering the hemoglobin A1C or the glucose, the impact of lowering that on the risk of cardiovascular disease. And what you can see that lowering the A1C by 1% reduces markedly the risk of microvascular disease by about 37%. But the impact of that lowering of glucose, correcting the glucose in the macrovascular heart attack or stroke is very little. And this particular study didn't even reach statistical significance. And the UKPDS is not an exception. This has been confirmed in later studies in the ADVANCE, in the ACCORD, in the VADT, where over 20,000 patients were followed for several years, and in whom the starting A1C different values, and it was reduced by different magnitudes to different levels. Regardless how much where you started and where you ended with A1C, the effect on macrovascular complication or in heart attack and stroke is very minimal. So these results together tells us that the risk conferred by diabetes to high cardiovascular risk is not due to hyperglycemia. Hyperglycemia might be one risk factor, might be a weak risk factor, but that doesn't what explains the high risk of cardiovascular disease in people with type 2 diabetes. So why then people with type 2 diabetes have so high risk for cardiovascular disease? We always, when we talk about diabetes, we focus on the hyperglycemia, which is due to the impaired beta cell function. However, we oftentimes forget or don't remember that people with type 2 diabetes manifest also a second disease, which is severe insulin resistance in liver and skeletal muscle. And that severe insulin resistance, that most likely what confers the high risk of cardiovascular disease, because the insulin resistance is associated, the presence of insulin resistance is associated with the large abnormalities and defects that are accompanying the insulin resistance, all of which are cardiovascular risk factors, and they are listed in this slide. Include, we talk about diabetes, obesity, hypertension, dyslipidemia, increased procoagulation, endothelial dysfunction, and so on. All of these metabolic abnormalities that are present in people with insulin resistant, they increase the risk of cardiovascular disease. So type 2 diabetes then is not a single disease. Type 2 diabetes is two diseases. One disease is the hyperglycemia, which is caused by the beta cell dysfunction, and that what damages the microvascular, the eye, the kidney, and the nerves. But type 2 diabetes has also a second disease, which is the insulin resistance, as you in the right. That insulin resistance causes also the development of type 2 diabetes, but that's through the insulin resistance syndrome, most likely what increases the risk of cardiovascular disease. And this recognition was led to the theory, what we call the common soil theory, that was coined by Dr. Stern in the 90s, in which the insulin resistance is the soil, is the fertile soil, in which on one hand diabetes grow, but on the other hand, the cardiovascular disease grow, and therefore this is what explains the close relationship between type 2 diabetes and cardiovascular disease. And this recognition has led to the thinking, to the ticking clock hypothesis, in which if you are, because insulin resistance, part of it is inherited, there are genes that you inherit from your parents that cause you to become insulin resistant. Of course, if you adopt a lifestyle that increase the insulin resistance, the severity of insulin resistance, like being obese or sedentary lifestyle, that will exacerbate your insulin resistance. And therefore, by the time you are born, there's a clock, two clocks actually, that start ticking. One clock that leads to the development of the cardiovascular disease, and the other clock that leads to the development of diabetes. And the question is, which clock will ring first? Which bell will ring first? If you, type 2 diabetes rings first, that means you become diabetic and then you develop a cardiovascular disease, or if you clot your coronaries, you'll get exactly the opposite. And the question now, what is the molecular etiology, what is the mechanism, how we can explain this close proximity between the cardiovascular disease and type 2 diabetes? This is a study that was published by Dr. DeFronzo over 20 years ago, in which he took people who are normal controls in the left bar, and he did insulin clamp in them. That is the numbers here are not important, but as you can see, the bar indicates the magnitude of insulin sensitivity of those individuals. So if you take people who are normal glucose tolerant and who are obese, who gain weight, you see that those people, their insulin sensitivity markedly decreased. Or in other words, they develop insulin resistance. Similarly, if you take people who are lean now, not obese, but who have type 2 diabetes, those people are also as insulin resistant as those who are obese. But more interestingly, if you take people who are normal glucose tolerant and who are not obese, but they have coronary artery disease, that's what you see the bar in the right hand, their insulin sensitivity is decreased as much as those who are diabetic or as much as those who are obese. So in other words, the presence of cardiovascular disease itself in the absence of diabetes is associated with severe insulin resistance. And so why then insulin resistance causes that cardiovascular disease and causes the diabetes? In order to understand that, we have to look at the mechanism of insulin action, and that scheme what describes the mechanism of action of insulin. Here is the plasma membrane of certain cell. For example, for our discussion, it's going to be a skeletal muscle cell or liver cell or endothelial cell in the vascular endothelium. And there is a receptor for the insulin that is sitting in the surface membrane. Now, in skeletal muscle, what insulin does makes glucose to go inside the cell. That's the role of insulin, to stimulate muscle glucose uptake. So when insulin binds to that receptor, it activates a cascade of second messengers that lead to the incorporation of the GLUT4 transporter into the membrane and the influx of glucose into the cell. The first member of that cascade is called the IRS1, and that activates the PI3 kinase, and then the AKT, and the AKT that mobilizes the glucose. So when the insulin binds to the receptor, it activates this cascade that ends up in glucose coming into the cells. Activation of the insulin signaling does also many other things. If this insulin receptor is sitting in the vascular endothelium, what it does, the activation of the insulin signaling leads to the production of nitric. and that causes the dilation of the artery. If this is sitting in the liver or in skeletal muscle again, it stimulates glucose metabolism. Now, what happens in insulin resistance, there is a block in the ability of the IRS to activate the PI3 kinase. The IRS is not phosphorylated, and as a result of that, it doesn't activate the PI3 kinase, and there's a block in the insulin signaling. Therefore, when insulin binds to the receptor, it doesn't drive glucose into the cell, and as a result of that, becomes insulin resistance. Insulin doesn't act. The problem is that insulin does many other things, and we all know that insulin is a growth factor, and once we activate the insulin receptor, there's a second arm for the insulin signaling that through the MAP kinase stimulates inflammation and proliferation. And we all know that if in a gestational diabetes, when there's production of insulin, the baby becomes too big because the insulin stimulates the proliferation of the baby cells. The problem is that when the patient is insulin resistant, whether it's inherited or he exacerbated that by lifestyle, then there's a block there. The glucose increases in the outside, and that increase in glucose stimulates insulin secretion, and the insulin binds more to the receptor in order to drive the blocked pathway further and to restore the glucose metabolism. But because the insulin resistance occurs only in one arm and doesn't occur in the other arm, the overactivation of the insulin receptor results in overactivation on that proliferative pathway and increase in inflammation and smooth muscle proliferation in the vascular endothelium. And that proliferation in the smooth muscle endothelium, the smooth muscle wall, that's the foundation in which the atherosclerotic process is sitting, in which the macrophages that engulf the LDL is sitting and start building the plaque. So this molecular mechanism explains both why insulin resistance increase the risk of cardiovascular disease or atherosclerosis and increase the risk of developing diabetes. Now, remember the clock that I told you about? This is exactly the clock that is sitting in your body if you are insulin resistant by the time you are born, so which is insulin resistance. What ring will build first, that depends on your luck. If you are lucky, for example, then you will inherit a weak pancreas that cannot cope with the high insulin demand, and therefore your pancreas will fail. You become hyperglycemic, you become diabetic. Then you come to see me. I will treat your glucose, I will treat your insulin sensitivity, the insulin resistance, and will reduce your cardiovascular risk. So I reduce your blood sugar, I protect your microvascular, and reduce your risk of macrovascular disease. But you are unlucky, and you inherited a strong pancreas from your parents, that pancreas will secrete enough amount of insulin to maintain your glucose tolerance. So you think you are okay, you are normal, but in fact, you are not, because the other process, the other part, the other clock will continue to work. And that will continue until you clot your coronaries and you come to the ER with acute MI, and then the cardiologist there who will diagnose acute MI will find your diabetes. And to show you the data for that, this is a meta-analysis of 13 studies that is about to be published, in which they took people who came to the ER with acute MI, but who never had history of type 2 diabetes. And what they did, they measured their blood sugar. And what they found is that over 20% of those people who came with acute MI without any previous history of type 2 diabetes, actually they had diabetes, but they didn't know about it. And over 30% of those who came without a history of diabetes with acute MI, they had pre-diabetes, meaning they are at high risk of progressing to diabetes in the next 5 to 7 years. So over half of the people who are coming without a history of diabetes, they either have type 2 diabetes or they have pre-diabetes. Now, not only that, if we look about the relationship between diabetes and cardiovascular disease, so those who came with acute MI now to the ER, if they didn't have diabetes in baseline, the risk of having diabetes, if having another event in the next in the future, in the next year, is relatively low, is only 5%. But if they had pre-diabetes, the risk is about 50% higher, and if they have type 2 diabetes, is even almost more than twice that risk. So the presence, not only people with acute MI have high incidence of metabolic glucose abnormalities, but also the presence of glucose abnormalities, either diabetes or prediabetes, will worsen the outcome and the prognosis of the cardiovascular outcome. So therefore, the diabetes and the cardiovascular disease are going hand in hand. The presence of diabetes will increase your risk of cardiovascular disease. It's as if you have a cardiovascular disease, and the risk of cardiovascular disease increases your risk of diabetes. So the question is how we can reduce that. If that is true, then if we reduce the insulin resistance, if we improve insulin resistance, if we normalize insulin resistance, we should reduce also the cardiovascular risk. I'm not going to go, and the drug that does that is the TZDs. I'm not going to go into details for that. Dr. DeFronzo is going to expand on that. But I'm going to just show you that in the proactive study, in which they took people with type 2 diabetes and cardiovascular disease, pioglitazone reduced the risk of cardiovascular disease as it did in people who are insulin resistant without diabetes in the IRIS study. But again, Dr. DeFronzo is going to expand on that in the next slide. Now, why acute MI is bad? Acute MI is bad, first, because it kills you. What is the most common presentation of acute MI, clinical presentation? Is a sudden death. Because most of the people who got MI, they die instantaneously, even before we, the medical personnel, can get to provide them with the help. But also those who survive the MI, the presence of acute MI will increase the risk of having heart failure. So heart failure is another important cardiovascular outcome in people with diabetes, which is also independent of the atherosclerosis. So if we take people with heart failure, and then we look into whether they have diabetes or if they don't have diabetes, we can see that the patient on the left side, you see the risk of death is over 60% increased if you are having heart failure and type 2 diabetes versus heart failure without type 2 diabetes. And the hospitalization for heart failure is almost double in the presence of diabetes. In other words, the presence of diabetes increases your risk of dying from heart failure or being hospitalized from heart failure, and therefore there is a special link between diabetes and heart failure, which is, I'm going to show you, it's independent of the acute MI. Now, heart failure is a big bag, a mixed bag, and there are many causes that can cause to heart failure. The most common cause of heart failure that we are familiar is the acute MI that hits, reduces the contractility of the left ventricle and therefore results in a heart failure. And that's what's known as heart failure with reduced ejection fraction, because the ability of the left ventricle to contract is compromised, and as a result of that, it doesn't pump enough blood, and it causes heart failure. So people with heart failure and reduced ejection fraction, or if you want HFrEF, we see that the presence of diabetes also worsens the risk or increases the risk either for death or hospitalization for heart failure in people who have HFrEF. Why is that? One cause could be because the presence of diabetes increases the risk of cardiovascular event. Therefore, if you have heart failure and then you have another acute MI, that will increase your risk of death. I have some other thoughts that can link this HFrEF to type 2 diabetes, but we don't have data yet, so I'm not going to bother you, but that's one of the possible explanations. But heart failure, it can be because of HFrEF reduced ejection fraction. You would see if you do an echo, you see the left ventricle is dilated, the wall is thick. That is the typical heart failure that we are familiar with. But there's another cause of heart failure. That is, patient come to you with symptoms of heart failure. He has exertional dyspnea. He cannot breathe when he goes up the stairs, 2 or 3 stairs. And then you think that he have impaired LV function, and you send him to the cardiologist to do echo, and you will find out that he has normal ejection fraction. So there's a heart failure with preserved ejection fraction, or what they call the HFpEF. Those patients who have HFpEF, when you look at the heart, they have normal ejection fraction, usually officially is above 50%. You will find that the left ventricle is not dilated, and you see the wall is thickened. And there are many reasons for HFpEF. 30 years ago, the most common cause of HFpEF was hypertension, because people have high blood pressure. Hypertension was not recognized as a killer as today, and therefore, when you have high blood pressure, you increase the strain, increase the pressure on the heart, the left ventricle is thickened, in order to overcome that pressure. And as a result of thickening of the left ventricle, it becomes stiff and doesn't relax. When it doesn't relax during the diastole, it doesn't fill up with blood. And when the left ventricle doesn't fill up with blood, it doesn't eject the blood when it contracts. But in recent years, there's an increase in the risk of half puff with preserved ejection fraction, and that's because of the increase in obesity and type 2 diabetes. And even in the case of the half puff, the presence of diabetes, you would see even it would confer much greater risk of death and hospitalization for heart failure, even greater than that with the half puff. The question is, why is that? And that is what we believe back is the obesity and the insulin resistance. And this is a cartoon that it tried to explain the mechanism why probably the presence of obesity and insulin resistance is causing and increasing the risk of death from half puff. So in insulin resistance, and tomorrow you're going to hear more about that when Dr. DeFronzo expands about the pathophysiology of type 2 diabetes. But what we believe is happening is that when you are obese, your fat cells are maximally enlarged because of storage of extra calories that you ate. If you continue to eat calories, push calories into those fat cells, they cannot contain any more fat cells. Therefore, the fat start to spill into the lean tissues, and that's what we call the ectopic fat. That's the yellow droplets here, probably you don't see it in the back, start to accumulate in the liver, cause fatty liver. That's what causes the insulin resistance in the liver. That's what causes the development of NASH. That fat start to spill in skeletal muscle. That's what we believe what causing the insulin resistance in skeletal muscle. The fat also start to secrete all kinds of adipocytokines that also contribute to the insulin resistance in the liver and the muscle. And what we believe is the same thing is happening to the heart. The muscle heart, the myocardial is no exception. And as there is overflow of fat and adipocytokines from the fat to the skeletal muscle, the same thing happening to the myocardium. So there's what we call the myocardial steatosis. And that myocardial steatosis that causes the fibrosis, the inflammation in the left ventricle, the stiffness, and the impaired function. Now, this is a small study that used MRI to look at the heart function and to measure the amount of fat inside the heart, and shows exactly the very same thing that I just told you. This is the MRI image for the heart. These are the ventricles, these are the atria. So they placed the measurement in the atrial septum, and then they looked into how much fat there is inside that muscle in the septum, and it's shown in the right. That's the size of the peak. The height of the peak indicates the amount of triglycerides in the heart. So the greater the peak, the more fat is in the muscle. And then when you look into those people who have half puff versus those who are controlled, you see that almost double the amount of fat in the heart for people who have half puff versus those who didn't have half puff. And if you look at, this is a measurement for diastolic dysfunction. They look into LV strain, and you see that the strain is decreased. The higher the strain, the better the contractility and the relaxation of the heart. And you can see that the strain of the people with half puff is reduced. And because those two things are continuous parameters, if you plot the diastolic dysfunction versus the content of the fat in the heart, you see a strong inverse correlation with a R value of 0.779, meaning the higher the fat in the muscle heart, the lower, the greater the risk of the greater impairment of diastolic dysfunction and the risk of development of half puff. So how we can solve this problem? If the over storage of fat in the body is what causes this, then if we cause weight loss, we're gonna improve this situation. And this is a study that showed exactly that. It took people with 25 people in each group, people who were hospitalized for half puff, and they randomized them to two groups. One group make them lose weight by diet and exercise, and the other group as a control. And as you can see, the main weight loss was 7 kilos in the weight loss group. And here you see in the y-axis, they measured what they call the 6-minute walk test. This is a test that shows the functionality of people with heart failure. And you can see in people who lost weight, it markedly improved versus those who in the control, where there was no significant change in the 6-minute walk, meaning improve in the symptoms of half puff just by losing weight. And we assume they measure also all kind of diastolic measurements that shows improvement with weight loss. They didn't look into the fat. Another study that we have done in San Antonio, in which we showed that improving LV insulin sensitivity will improve LV diastolic dysfunction and likely to resolve the situation. This is a study here. We measured the myocardial insulin sensitivity with PET scan and glucose, DFG. You can see that in people with type 2 diabetes, there is a marked decrease in the insulin-mediated muscle glucose uptake, myocardial glucose uptake. And once we treat those with pioglitazone over 6 months, we got restoration of that muscle glucose uptake back to normal. And when we look at the diastolic dysfunction, you see again here measured with the MRI as E to A ratio, that in people with diabetes there is a decrease in the EA ratio, and that decrease in the EA ratio was corrected upon improving myocardial insulin sensitivity, and similar things at the deceleration time. That's another measure of diastolic dysfunction. So improving insulin sensitivity of the myocardium will restore or will correct the myocardial diastolic function, either with pioglitazone in this case or with weight loss, which we assume depleted the triglycerides from the heart and will improve the diastolic function. Of course, this is in our study, the systolic function was normal because those people don't have myocardial infarction. They are normal people. Their ejection fraction was 60. And after we treated them with pioglitazone, it didn't change because they have normal ejection fraction. The impairment in those people is in the diastolic function. So therefore, to summarize, diabetes and atherosclerotic cardiovascular disease, as I showed you, are two manifestations of the same disease. The question is which one will be manifested first. The clinical implication for this is if a patient comes to our care and he had a history of acute MI, then even though he denies having a history of type 2 diabetes, we should look for that history, for the presence of that type 2 diabetes, either diabetes or pre-diabetes. We know at least from the studies that about half of the patients with acute MI without history of diabetes are going to have some sort of impairment in glucose metabolism. The second conclusion is that insulin resistance is likely the underlying etiology for this close relationship between type 2 diabetes, atherosclerotic cardiovascular disease, and heart failure, even in the absence of atherosclerosis. And improving myocardial insulin sensitivity, either with weight loss or with pharmacotherapy, is going to improve diastolic dysfunction. We don't have information whether that also improves heart failure, yes or no. Thank you very much for your attention. Any questions? Okay. Thank you.
اوكي. بس بدي اقدم شكر خاص اللي سهوة شركة نوفارتس الراعي الفضي، واللي هي دائما بتكون في كل مؤتمر بخص السكري والغدد وغير ذلك. شكر خاص، شكرا لشركة نوفارتس. قبل ما اقدم بدي اقدم هلا كمان my second moderator, our very young senior diabetologist, very young senior diabetes, دكتور ترزي. دكتور ترزي راح يقدم لنا البرزنتيشن الثاني. هو senior diabetologist, country representative of Palestine at the Diabetic Foot International and at the International Working Group on Diabetes Foot.